Good morning, everybody. I'm very much thankful to the Scientific Committee Chairman, Dr. Partho Vishwas, and the organizing committee to giving me an opportunity for the instruction course 121, that is the Empower Yourself by Decoding the IOL Power Calculations. We have very esteemed faculty for the instruction course. We have Dr. Tejas Shah, Dr. Arshul Tak, Dr. Sail Vasavada, Dr. Somil Kothari, and myself. We all are practicing nearly more than 15 to 20 years for the cataract surgery. All are the very leading faculties in this field and they are all speaking on the national and international forum for this talk. So we start with our talk. Dr. Arshul is a little bit late, so I am starting with my talk. The decoding the newer generation IOL power calculation is implication. Now, in cataract surgery, there was a good visual outcome at 2000. In the era of 2010, in the next decade, it was a good refractive outcome. But now the demand of the patients are the excellent refractive outcome. So we have so many updated instruments, and we have already one talk for this, updated all these optical biometers by Dr. Arshul. But the updated instruments give the very precise and axial length and the measurement of the keratometry, which is very much precise with these newer generation machines like Galileo or IOL Master 700 or color LED. All these machines give us very good precise anterior and posterior corneal power calculations, and then gives the total corneal power. So we have a very good excellent measurement, we have very good corneal measurement, but even though we are getting so many refractive surprises, and by the source of error, the magnitude at present, the 76% of the cases where the ELP is the one of the main culprit for the source of error. So all the formulas which are at present focused is based on the find out how to go for the good effective lens position calculations. So now the classification of the IOL power calculations from the historical based method to the regression based method. Now the Vergen's formula, which is based on the Gaussian optics, they are using the different variables. Variables like the two variables like anterior chamber axial length and the corneal power. 3 variables, they are considering the anterior chamber depth. 5 variables, they are considering the lens thickness and the white to white by the Barrett universal. And 7 variables formulas which are using the preoperative refraction and the age of the patient. So this is nowadays the accuracy or range of the commonly used formulas up to the 5 years back. That was our old third generation formulas like Oladevan, OFER-Q and SRKT, and you modified according to the axial length by the Wong modification. You can get better results with the normal anatomy. But the patient have all other type of anterior segment anatomy like small eyes or a small anterior segment with the normal axial length. In such cases, the newer version of the IOL power calculations, they works much better, particularly Barrett formula, Olsen formula, Hill RBF formula. So all these formula based on the ELP estimation, and the predictors which newer generation formulas which are taking is the lens thickness as one of the main part as a variable, and certain formulas which are considering the cornea part for the better keratometry measurements. They are considering the corneal asphericity and the posterior anterior ratio like a panacea methods. So in 2022, so many formulas we have. From left side, there was our old third generation formulas. Now in the 2015-17, we have Barrett 2 Universal and Olsen. But now we have plenty of formulas which is available. At present, the current and all these formulas are available online without any charge majority of them. So we have accessibility of all of them. But how to go for it? At present scenario in world, the top formula which is commonly used is the Barrett Universal 2, Ken formula, EVO formula, Hill RBF calculator, Olsen formula and Panacea calculator. But most important part, without any regular optimization of their performance, no one is superior than the traditional formulas. So we go for each of them individually, which are the key factors for the why this formula is more important for the newer power calculations. One is the Barrett suite. Barrett suite has a 3 component, which has a non-toric component, which is a Barrett Universal 2. It has a toric component, Barrett toric, and post-refractive surgery, Barrett 2K. which is available in majority of the optical biometer. It is a theoretical model generation formula. Most important thing is that it is a thick lens formula. So it is based on the IOL model like a high meniscus lenses. And for the Barrett toric formula, toric IOL theoretically takes account by the posterior surface of the cornea. So you can use both the actual measurement of the corneal power and you can go for the nomogram method. Barrett suits has also two types of factors. One is the lens factor and one is the design factor. This lens factor is given by the Barrett for the individual IOLs. But the design factor is very much important because it gives the lens transition from biconvex to the meniscus. So when you are going for the operating any patient who has extreme high myopia, then the design factor has to be changed in the Barrett formula. This is inbuilt in the majority of the Barrett formulas. APA CRS website, this is very much easily available online. You can go for it. Here they have added two more things. One is Barrett treatment formula. So post-refractive surprise you can manage very well with it. And Barrett TrueCat toric calculator, which is incorporated now. That is mainly used for the patient who have been undergone the pre-refractive surgery with the toricity, residual toricity, and you can correct that with the toric IOL. The Hill RBF calculator is again newer artificial intelligence formulas. They are artificial intelligence with a machine learning pattern recognition and data interpolation. That is known as adaptive learning. And this uses the 3-point database of the corneal curvature, antechamber depth, and axial length. And this has been already fed with the measured by the optical biometry, and this gives a results of the by artificial intelligence. Recently, Hill RBF has again extended beta version introduced, and the 3.0 version is also been introduced, and they have a data set of the more than 1,000 high hyperopic and high myopic patients, extreme high hyperopia and extreme high myopia also. So there gives a much better results with the artificial intelligence in a high hyperopia or high myopia. I think the next speaker is taking how to deal with the high myopia and high hyperopia. Another formula is a LADA super formula. It is also based on the artificial intelligence, but the important part in this LADA super formula is all these versions formula or ray tracing formula, they are a fixed base equation. You put your patient data, you have an equation, and you are getting the output. So it is a fixed one. It is a static formulas. Like our AI artificial intelligence formula, like a Hill RBF and Clark, is a data set limited. So whatever the data has been there, artificial intelligence capsulated it. But the LSF means LADA super formula, which is an evolving formula. So whatever the at present level, it is online updated every time. So it is a real-time formula. So whatever the data at present world is getting it is already updating by itself. So it is an artificial intelligence which is updating on itself by its own. It's a real-time one. So it gives this graphical presentation in LADA super formula. And another important part, the next version of LADA has introduced the refractive index inclusion. So device refractive index inclusion is very much important. Why? Because our measurement of the cornea is mainly based on the corneal curvature, corneal power. But all the gauges which are giving the curvature power, not the actual power what we are putting in the IOL power calculation. So suppose your corneal curvature is 7.3. The one machine has considering the refractive index of 1.3375, another machine is considering 1.3337. So both are the giving refracting index and both are giving the different powers. So this thing has been taken care by this LADA's formula. The LADA's has also given a formula in such a way that it can be incorporated in the optical biometer. So now our optical biometer is also smart, like our smartwatch. So whatever though you are operating the patient, you are getting the results. That result has been automatically fed in the optical biometer, and that will be automatically corrected in the next patient. So this formula is now evolving in such a way that our optical biometer is going to be smart in the next future. Another is a Panacea calculator. The Panacea calculator, which is available online, and every NTS segment has to be download this calculator, because it is not only helpful for the IOL power calculation, but it is helpful for the management of the glaucoma patient, keratoconus patient, refractive surgery, how much residual bear will be there. So everything will be given by the Panacea calculator. So it is very useful tool to download for the NTS segment surgeon. It also gives the toric calculator, SIA calculations, your surgeon A constant calculations, post-operative toric calculations, everything has been fitted in this calculator. So it is very useful tool for anti-segment surgeon. Now what it gives, not only the biometric data, it also have a topographic data. But topographic data it considered as a posterior anterior ratio and the corneal sphericity consideration in the IOL power calculation for this formula. Another important feature in this calculator is a selection of the patient for the multifocal or EDOF lenses. It gives the defocus curve. So you suppose patient have a more near vision or suppose patient wants a more intermediate vision, you can select which trifocal will be best for the patient according to patient's data, because it is considering the corneal sphericity, PA ratio, everything has been considered. So it will give the precise idea whether this patient fits for the visual IOL or a panoptics. So you can consider according to that. So you can get the patient's presumed bifocus curve for every individual lens. Another important part in the calculator is the capsular back tilt factor. So which is another important part in the toric calculations which is coming up, and we will talk regarding that in our last talk. Ray tracing technology. All third generation formulas are based on the Gaussian optics, that is a thin lens based formula. So cornea has a single plane, lens has a single plane, and we presume what will be the effective lens position. Now ray tracing analysis was not there at that time, but because of advancement in the instruments, we are getting each and every point of the cornea. And this point has to be exported through the Zimex type of optical softwares which are used in the telescope. So we are getting the very good corneal topography in such a way that we can use this data and considering what is the corneal power exerted at which level of the cornea. So ray tracing formula performs better where the effective lens position calculations formulas or thin lens based formulas are not working well, like abnormal corneas. Like scarred cornea, corneal sphericity is not good. In such conditions, I think Dr. Thesis is talking the talk how to manage the patient having an abnormal cornea. So Olsen formula, which is another one with the ray tracing one, it is considering as a C constant. C constant, it is based only where the lens will be positioned in the capsular bag. So it is a C constant, depends on the crystalline lens anatomy. It is independent of the reading and the axial length. So it is more effective in the post-LASIK formulas. Another formula which is coming up is the EVO formula based on the theory of the emetropia factor. It is very good calculator. It has option for the post-myopic LASIK or PRK also. It is also two-part important in the toric calculator. EVO toric calculator is now emerging as a newer toric calculator which is considered as a better than the Barrett one, because it has a theoretical posterior corneal astigmatism prediction and it has a thin lens modeling of different types. And CAN formula, it is also one of the very good coming up formula which has a thick lens formula and which has a gender variables. Just briefly going for, because I am out of time, Paul DGS calculator, which is also a artificial intelligence and the optics based calculator, which has a very good results in the history of post-refractive corneal surgery patients. And the T2 formula, those who are using still SRK-T, this is another formula which should be downloaded. It can be downloaded easily on your desktop, and it gives nearly 10% more accuracy than what your SRK-T is giving. Thanks for your attention. I invite Dr. Harshul for giving his talk about the different optical biometer.
Thank you so much, Dr. Twinkle, for making me a part of your wonderful course, which we have been doing for many years in AIOC. So we all know that once the optical biometer IOL Master 5 days was introduced in 1990, it changed the way the axial length, especially in all the parameters, we started measuring with the exactitude. So let's see what are the advances in biometers. So we all know that biometry is the principle of applying mathematics to biology. So broadly, they were ultrasound based system, and there is optical biometry based system. So the A-scan ultrasound, it uses sound wave frequency of 10 megahertz and it has accuracy of only 0.1 millimeter. The biggest limitation of ultrasound A-scan is that it does not depend on patient fixation. It just measures the anatomic axial length of the eye from anterior pole to the posterior pole. And second is that it measures from the internal limiting membrane. Whereas the optical biometry, it measures till the photoreceptors, which is the true axial length of the eye. And secondly, it always measures along the visual axis of the eye. So these are the two advantages with optical biometry gives. And of course, resolution is far more better than the ultrasound measurement. So all the biometers, they are basically based on the principle of laser interferometry by Michelson. So IOL Master 500, it is based on the principle of partial coherence interferometry, and it uses a 780 nanometer multimodal luminescent diode. But disadvantage is it only measures axial length optically, and it uses slit lamp imagery to measure anterior chamber depth and other parameters. And so that was the biggest limitation of IOL Master 500. Whereas LensStar and Biometer, it is based on optical low coherence reflectometry. It uses a 820 nanometer superluminescent diode to measure corneal thickness, ACD, lens thickness, and axial length. So all the parameters it measures, they are optically measured, which are more accurate. And the K readings are calculated from 32 reference points in two circles, which are at the 1.65 and 2.5 millimeters. As you can see here, two circles of 16 point each. So basically, if we see the difference between partial coherence interferometry and optical low coherence interferometry, the difference is in the two aspects. First is the light source which they use, and second is the optical setup of the interferometer. So in PCI, like an IOL Master 500, there is a dual beam setup which is used, and in the OLCR is their proprietary rotating glass cube system which is used to measure the axial length and all parameters. So the disadvantage is that there's a 780 nanometer MMLD which is used in PCI. It creates a measurement peak, and along the in front and behind it creates a secondary maxima. So there is it's not the exact measurement, whereas the SLD which is used in the OLCR, it gives a continuous light spectrum, so it measures all the peaks optically. So if we look at this, is the setup of the partial coherence interferometry. We all know that there is a light source which gets splitted by this mirror here, and this light source when combined returning back from the eye, so it measures by this principle, whereas OLCR, it uses a proprietary glass cube system which is more accurate. So that's how we get all the measurements which are optically driven. And look at the AL scan, again it is also based on there are various biometers which I'm now telling you about, that what principle they use and what is the method of capturing. So this is the partial coherence interferometry based system, again AL scan. It uses 830 nanometer superluminescent diode and uses 970 nanometer LED for keratometry, pupillary size, and again 525 LED for white to white. We look at the Aladdin. This is again based on optical low coherence interferometry. It measures all the parameters, because these are the parameters which we require for all the newer generation formula, as Dr. Twinkle mentioned. The universal Barrett 2 and all the formulas, they require ACD, CCT, lens thickness. So limitations were these, with these biometers were of the penetration in denser cataracts, and they only measure anterior cornea. So now came the swept source based OCTs, this biometers. So IOL Master 700 is one of the device which uses swept source OCT. It uses a scanning rate of 2000 scan per second a wavelength of 1055 nanometers, and it provides a two-dimensional OCT scan. And so we get all the information about corneal thickness, ACD, lens thickness, and axial length. And it uses a telecentric K in 3 zones, 1.5, 2.5, and 3.2 millimeter, and using a refractive index of 1.3375. So this was the IOL Master 500, as I said, based on partial coherence interferometry, and now this is the IOL Master 700, which uses swept source OCT. And so if you look at this, it's a telecentric keratometry which is used in 3 zones. So we can really see with the use of OCT, we can see the foveal pit, and if we see a foveal pit, then it's a good fixation. If you don't see, so this is how the 3-zone telecentric keratometry is used in 3 zones. We get 6 spots at 1.5, 2.5, and 3.5 millimeters. So the another advantage of IOL Master 700 is that it gives us the total keratometry. So this is the device which not only gives us information about anterior but also about posterior corneal surface. So we don't need to assume anything that what will the posterior corneal power. So it has unique formulas like Barrett TK universal to Barrett TK toric and Barrett true K with TK. So it gives the total keratometry values, which is very helpful, especially in post-refractive surgery patients. It also gives us the angle kappa, that's the Chang CW chord, Chang varying chord it gives. We all know that it should be less than 0.5. Coming to OA2000, personally I'm using this instrument for last many years. It's also based on swept source OCT. It has scanning rate of 1250 and uses wavelength of 1060. It also measures axial length, ACD, CCT, and lens thickness. And it has a placido disc which has 9 rings. So 256 points are there on each ring. And we obtain the K value at different diameters. We can choose whatever diameter we want. And pupillae, this white to white and pupillae size, they are obtained from video analysis. So this is also based on swept source OCT, has very good penetration. Argos is again based on swept source OCT. It gives, it uses 3000 AS scan and wavelength of 1060. And this is the latest from Heidelberg. There's the Anterion. Anterion is again swept source based OCT, uses wavelength of 1300 nanometers. And it measures the aqueous depth from corneal endothelium to the lenticular front surface, and again gives keratometry in the central 3 millimeter zone. So we need all these advanced biometers to use the newer all formulas which are more predictable, more accurate. So they provide repeatable and reproducible measurement in different ocular parameters, and they provide good accuracy in IOL power calculation. Thank you very much. Any questions, I'm happy to answer.
Thank you, Arsu, for elaborating all these newer optical biometer in depth. Now I invite Dr. Soumil Kothari. Everybody knows a Bombayite, a senior faculty. He will talk us regarding the how to manage the high myopia, very high myopia, hyperopia, very high hyperopia. Patient has undergone the vitrectomy surgery. How to manage those cases for the IOL power calculations. Dr. Soumil, please.
Thank you. It's good to see all of you after, I think, 2 years, having back to face-to-face conferences at the All India level. And it's going to be a wonderful conference in this wonderful venue of Geo World Convention Center. While they are setting up my slides, I thank Dr. Twinkle to include me in this course, in this fantastic course of very important of how to do your IOL power calculations. And my talk is on how IOL power calculations will be done in very short, very long, and post-vitrectomy eyes. Thank you. Lovely. Thank you very much. So I divide my talk into two parts. One is about short and long eyes, and the second one is about post-vitrectomy eyes. Now, coming to short and long eyes, what are short and long eyes, first of all? Well, we all know the bell curve, and 95% of us, what we in so-called normal, will fall into the normal category, and on the either two ends are the 2.5% and 2.5% of the extremes. So this is where the short and long eyes come into play. Normally we say that less than 22 millimeters of axial length is considered short, and various studies have said that either you can consider more than 25 or 25.5 or 26 is considered as long eyes. So what's the problem with short and long eyes? Well, there is no problem actually. It's just about the expectations of our patients from the cataract surgery itself. Everyone wants a perfect outcome after cataract surgery, so the expectations are running very high. And in reality, although we all give good, perfect outcomes as far as refractive error is considered in the normal category of eyes, as far as short or long eyes is concerned, we sometimes fall short. And that's where there's a mismatch between expectations and reality. So what's the solution? How do we achieve target refraction in such eyes? Well, there are two components to better biometry. One is having better equipment, and second is better IOL calculation formulae. Let's talk about each one. Coming to the equipment, as Harshul has very eloquently mentioned, it's very important to update ourselves and have the best biometers which are there available. There are many such biometers which are available. Just to very commonly available instruments are the LensStar and the IOL Master, and we should invest in such modalities because they really help us in difficult situations. So the advantages of these optical biometers are they measure the true axial length, they give us the central K measurements, they are highly accurate and repeatable, and they are non-contact. They have faster measurements so that the patient eye fatigue time is less, and some of them have inbuilt newer IOL calculation formulae as well. So then what is the role of the old ultrasound biometry? So it is still used for dense cataracts whose axial lengths cannot be ascertained by optical biometers, and also for confirmatory role for doubtful measurements obtained by the optical biometers. So this comes to the biometry part. Let's talk about the IOL calculation formulae in short and long eyes. So there are various formulae available. Which formula to choose is always a conundrum. So I've just broadly divided into the older and the newer formulae. So the older formulae, like the SRK1, SRK2, were based on regression and basic theoretical optics, whereas the newer ones are based on more advanced theoretical optics, either or ray tracing or artificial intelligence. In the older ones, only 2-3 variables were accounted for, and here there are many more variables which are accounted for, leading to more accurate outcomes. And the older ones were less accurate in extremes of axial length, and definitely the newer ones are more accurate in terms of as compared to the older formulae. So this is how the newer formulae, the newer generation formulae like the Barrett, the Olsen, the Kane, they all work very well. So how do the formulae compare? Well, I've borrowed heavily from this article which was there in ophthalmology, and it compared 8 different formulae, the newer ones as well as some of the older ones. So let's talk about the variability with the IOL power. Well, you can see the more variations in the formulae, the less accurate it is. We want a formula which is very stable. We want a straight line more or less across the board, whether it's a very hypermetropic IOL power or a very myopic IOL power which is used. And here you found out that more or less the red line, which is Barrett, as well as the purple line, which is the Olsen, fared very well. Variability with axial length, which is my core topic. Again, you can see the flat line is more consistency, is with the Barrett again, and the Haggis without the Bangkok modification fared very well. But somehow with the Bangkok, they found out that it didn't really serve very well in the longer axial lengths. With K readings also, they did study that, and again it showed that the Holiday and the Barrett were quite repeatable across the board with the keratometry readings. As well as with AC depth, again the Barrett and the Haggis fared very well. Somehow the Olsen didn't do very well with the AC depth. And they studied the lens thickness. More or less, almost all the formulae were comparable except for the Haggis formula. Now this graph talks about the prediction errors based on the axial length. Here we are talking about the shorter axial length, which is blue. The green is the normal and the red is the longer eyes. And here these are prediction errors. So the bars should be as less as possible. The longer the bar, the more error it is. So here you can see in the leftmost there are minimum bar height, which is there in the Barrett and Olsen, and towards the right we go with the increasing bar. So again this shows that the Barrett and Olsen is quite good in across the board of axial lengths. And what about the ultimate refractive error? How many number of cases were on target refractive error? Here it showed that less than 0.25 prediction error was there between 42 and 50% of the eyes across the board, but again slightly more in the Barrett, and also less than half a diopter as compared to the target variability was there between 72 to 80% of the eyes, again more so in the Barrett and Olsen. So this is a range which Dr. Twinkle has also shown this slide, that this newer formulae work across a long range of axial lengths. So what's the long and short of it ultimately? If you take one slide, this is it. This is a take home message, that the Barrett is what I use, the Barrett Universal 2 formula has emerged for all of us, for at least most of us, as a go-to formula for all axial lengths. Let's talk about post-vitrectomized eyes. What's the problem with post-vitrectomized eyes is about silicone oil, essentially. So how to have the correct axial length measurement in silicone oil filled eyes? What about getting the correct IOL power? And the third and the last part is choosing an appropriate IOL material in silicone oil filled eyes. Again, let's talk about each one in length. So why is silicone oil a problem? Well, silicone oil reduces, the conduction of speed in silicone oil is slower than that of vitreous. In vitreous, it's 1532 meters per second, whereas in a silicone oil, it's either 980 for the lesser centistokes, that is 1000 centistokes silicone oil, and if you use a 5000 centistokes, it is 1040. Also, the higher refractive index of silicone oil leads to a hypermetropic shift of refractive error by around 5 diopters, anything between 4 and 8 diopters. Also, when we take our measurements, there is poor quality of echoes and there is reduplication of echoes on the ultrasound. So what's the solution? Well, if you have a basic biometer, very simply you can use a correction factor of 0.71. It is studied, and which is used for the more commonly used of 1300 centistoke silicone oil to measure the correct axial length. For example, if you have a axial length which is measured it shows 37.5. Silicone oil filled eyes in the normal mode, it gives a very long axial length. You just multiply it by 0.71, so you get the correct axial length of 26.63. This is what you can use as a basic formula. But better still is to change the mode to silicone oil fill eye if your biometer allows. And of course, the best one is to use optical biometers like the LensStar or the IOL Master 700, because you don't really have to do anything much. It gives the absolute correct axial length. But what if you don't get a good scan? Well, what very important preemptive solution is to measure the axial length prior to VR surgery, so that we can use this at a later date when we are going ahead with the cataract surgery. Also, the second one, another thing which we can do is that we can remove the silicone oil and then remeasure the axial length and then later on implant the IOL. Also, which is studied is intraoperative aberrometry or retinoscopy, which deals with removing the oil, doing a retinoscopy, and then intraoperatively, and then going ahead with the IOL selection. Or lesser accurate is using the actual length of the contralateral eye. So this is about the correct measurement of the actual length itself. Talking about IOL, briefly about IOL power calculation in such situations. This was an article which studied 8 formulas again, which combined phacovitrectomy, and it showed that you can see on the top, the Kane and the Barrett Universal 2 fared better than the others, albeit by a slight margin. And the third part is about which IOL material to choose. Well, we all know that we have to avoid silicone oil in such situations, and best to use either acrylic or PMMA lenses. So what are the conclusions in summary? Use newer biometers to measure the actual length accurately. Use newer formulae like Kane or Barrett for IOL power calculations, and avoid silicone material of IOLs. So as Shakespeare would put it, oil's well that ends well. Thank you.
The Indian Shakespeare.
Thank you, Dr. Somil, for such a nice narration about the post-vitrectomized eyes and the very high axial lengths. Any questions regarding it? You can start.
Just for the clarification of the audience, Samir, I always get confused that, when the oil is in the eye, what power do you choose? So could you guide that if the oil is to be removed or if it is not to be removed, from what you measure, what power should you keep?
Very true. So there are two situations. Either we are intending to remove the oil at a short, and to keep the oil only for a short duration, or we intend to keep the oil for a longer duration. So all this what I spoke was only to intention with to keep the oil for a shorter duration, then you do all these things. But if you really want to keep the oil for a longer duration, then what I do is simply just add around 5 diopters to the IOL power which is calculated, and then implant that because of the higher refractive index and the hypermetropic shift which happens.
So that basically means you choose a more myopic target. So in your biometry, just say put a target of -4, and whatever the power comes, you choose that.
Exactly. Yeah. So if the IOL power calculation comes out to be 20, I'll just choose 25 or 26, something like that. Thanks.
Excellent. And Dr. Tejas.
Yeah, in fact, adding more to it, that's what is our general fundamental. What would you prefer, a patient with 6/9 vision and ametropy, or a patient with 6/6 vision but plus 2.5? Well, definitely, that's the reason we always want to err on the myopic side, with silicone or without silicone.
I invite Dr. Tejas, everybody knows him. He's talking about the abnormal corneas, how to manage the post-refractive surgery, post-RK patients, post-keratoplasty, and particularly focus on how to calculate the IOL power calculation in the keratoconus patients. So what do you, Dr. Tejas?
Okay, sorry for that. A very good morning, and like Somil said, meeting all of you after a long time. And I thank Twinkle for keeping me as a lucky charm in all his courses. And we have been doing this course for now more than 5 years. 5 plus 2, that is 7. IOL power calculations in abnormal cornea. Well, so everything here is not normal. And it will be a tall or a very optimistic goal that we end up with a emmetropia. But let's try to do something where we have at least a functional vision for the patient, and that too without glasses. So I'll just try to at the outset clarify what is an abnormal cornea, especially for IOL power concern, because I believe almost everyone sitting here has bent and bruised the cornea at one part of their life, or in 1 week of their practice, at least once or twice or more if you are a refractive surgeon. So the poor cornea is always the first victim, and as we understand our Duke Elders type of anatomy, cornea is the first refracting surface, and that is also the most important refracting surface. And so whenever this particular structure of the eye is bent or bruised, which is because of the refractive surgeries or any kind of trauma, we always end up with a lot of issues. So I'm going to talk about the post-refractive surgery corneas. These are abundant right now, and probably in 5 years' time, every third patient who comes to you for a cataract would already have a corneal refractive surgery done on their cornea. And there we have LASIK and PRK and the RKs. Luckily, the RK patients are now dwindling, and less patients of RK turn up for cataract. But then against that, the LASIK and PRK has exponentially increased. Corneal scar and dystrophy, these are the poor patients, and they always are going to struggle for a good vision. So why not make them happy with less glasses or less of irregular astigmatism? Corneal degeneration, keratoconus, well, somehow, just like we always think that in the present situation, the number of patients with glasses have increased. Well, it is not the number of patients of glasses have increased, it is the awareness which has increased. And similarly, the number of keratoconus patients. Probably a lot of you might have seen a patient who is 45, 50, 55, and when you do a corneal study, you might say, well, he had an keratoconus, but it did not progress, but he still had a keratoconus grade 1 and grade 2. So all these patients are going to be a challenge, and also the post-keratoplasty patients. Luckily, nowadays, there are more of lamellar surgeries rather than total penetrating keratoplasties. So let's first of all talk about the subgroup, the corneal refractive surgery patients, especially the LASIK and the PRK, and trying to do IOL power calculations. So to go back to our basics, the regular cornea, the regular formula, when you use, we were not taking effective lens position into account. In these regular formulas, they consider that cornea and IOL are assumed as a single plane, but it is not so. We all have now understood, thanks to the companies which have made us understood, which have explained to us all this. They also have to go ahead and innovate new machines, and we have to buy them. What actually happens in a conventional keratometry? Again, going back to the basics, it measures the anterior corneal curvature only. It also presumes that there is a fixed ratio between the anterior and posterior corneal curvature. And now, like I said, probably in 5 years' time, every third patient is going to have his or her anterior and posterior corneal curvature changed. The keratometric index of 1.3375 is used to calculate the corneal power, and it does not take into account the corneal thickness. Same way we have started understanding the importance of corneal thickness in glaucoma, here also the corneal thickness has started becoming an important factor. What happens in a post-LASIK patient? Well, you all know, well, this is a bit of an exaggeration. It is not such a top hat in this prolate cornea days, but well, just trying to explain to that this ratio is changed. What are the problems if we use the conventional IOL power calculations? Well, like I showed in the previous slide, there is an abnormal Gulstrand ratio. Effective corneal area. Well, this is something very important. Whether you are measuring which part of the cornea or whether you are interpolating the data in the visual axis. And of course, very effectively talked about the wrong effective lens position estimation. So we need to evaluate the true corneal power. Like I said, the cornea, the poor structure is always bent and bruised, and that's why we need to measure the true corneal power. And Herschel very well explained the different types of machines. Because of the time constraints, I'll not go into all those things, but we have to understand that the two main important technology we are having right now is the slit lamp or the Skymflux technology and the OCD technology. The instruments are Pentacam, Galilei, and Cirrus. And I can also mention that here we have now Pentacam XR, which also measures the axial length. So two main important keratometry readings are, one is the total keratometry, which like I believe Saumil explained, which comes along with the Allmaster 700, and they take into account the anterior and posterior curvature both, and or the Hollard equivalent keratometry report. These are the two very important measurements which makes our IOL power calculation more precise. So how to tackle this issue, the post-refractive? Well, like I said, use the measured that is the total TK which comes with the IOL Master 700, or estimated applying correction factors which is in the EKR in Pentacam. Like I said, they interpolate the data. They measure, they have no blind spot, which is the advantage over the total K. They have no blind spot, but then they interpolate the rest of the data after measuring the central 3 mm. Use formulas like not relying at all on corneal power. Well, this is something very important. Many times we have patients who would not even know that a refractive surgery was done 20 years back, or would not want to tell you if their spouse is with them. So it could be like the formulas of without corneal power are the Aramberry, the double K, the high gaze, the Pressner, the Olsen, and the Oculix. These are the formulas which have started helping us, even if we do not know the corneal power, the pre-surgery corneal power. Again, coming back to the same conventional, use the measured or the estimated true power. Very, very friendly and very important aspect of our IOL power calculation is the online ASCRS post-CRS calculators. This is really something probably in the entire website, this is one thing which we all frequently use and visit probably. Barrett True K formula, which is again online, or it could be incorporated into IOL Master 700. So this is just like, if you don't want to spend money, go online. If you have a lot of money, you can buy IOL Master 700. Holiday 2 is the post-CRS version, where equivalent keratometry in Pentacam HR is used, and the axial length is also used. This is if you are doing your IOL power calculation, though I don't do much, this is a very familiar page that everybody would be aware of in using it. Three main subgroups I would say. These are the formulae where you have everything with you. Your own patient or a patient who's carrying a file 10 years or 15 years before the surgery and having all the data, pre-operative refraction, K readings and everything. Well, you can very well go ahead and use this formulae in this group. This is where we have the keratometry but not the refraction, so some data is missing. And these are the formulae where you have nothing with it. The patient is absolutely new and has no knowledge also, and then you can go ahead and use these formulas. Very important again is the Barrett True K formula, and this is something where the True K IOL power is used, which comes from the IOL Master 700. Let's talk briefly about the formulas which are not relying in keratometry, especially for the corneal refractive surgery cases. The one very important and frequently used is the Olsen formula. Why? Because, and the C constant. What is the importance of C constant? Dr. Twinkle briefly referred to it. The C constant defines the IOL position in terms of the crystalline lens anatomy. So it does not depend on the K reading nor the axial length. So it is bypassing a lot of other data which is there, which is usually supposed to be filled up in the other formulae. Let's talk about, so that was all about the LASIK patients where the corneal thickness was also altered. Let's talk about RK, where remember that the thickness is not at all changed. It is only the entire curvature which is changed, right? I believe everybody understands what I'm trying to tell you, but still it is a challenge. Post RK, well again, like I said, measuring the keratometry is the most important thing. Use several devices to measure the Ks and use the flattest K as average K for calculations. I'll tell you the reason why use the flattest K. And sometimes even measure the keratometry at different time of the day and call the patient for a couple of more visits if that is permissible. Permissible because you might not know whether this K is a stable one or not. Average of 1 mm, 2 mm, 3 mm and 4 mm ring values of topographer always helps. Average central power in ASCRS calculator has to be put in, and we should have an access to a modified version of Holiday 1 or Aramberry and the double K methods. This was a very nice paper which actually which actually told us that the accuracy of the IOL power determination can be improved if the flattest calculated K is used in the IOL determination and myopia is targeted as refractive error. So please keep in mind that for post-RK, use the flattest K possible. And like we keep on telling you, always aim for myopic target. And the rule, a certain rule is minus half diopter for 4 cuts RK, which we rarely see, 1 diopter for 8 cut and 1.5 or more for 12 or more RK cuts. Such patients, intraoperative aberrometry is also less accurate, so you're not going to be able to take the help of that. Do non-dominant eye first. Practically, this is not always possible because it also depends on the type of cataract inside the eye, and we have seen that the dominance sometimes changes with the cataract evolution also. And adjust in the other eye accordingly. Of course, we cannot do a simultaneous bilateral cataract surgeries in such patients. Avoid toric and multifocal lenses and use only monofocal IOLs. Again, coming to this paper which says that the OCT formula and the Barrett 2K were comparable to the double K Holiday 1 method on the ASRS calculator. However, no formula was able to predict 80% of eyes within 1 diopter of target refraction at more than 4 months post-operatively. Refractive stability when, well, post-surgery, if you have done a cataract surgery on a patient with RK and you want to actually measure the refraction, what is a good time? For 4 weeks, minimum 4 weeks for 4 RK cuts and at least 2 to 3 months for 8 RK cuts. And post that only you will be able to say that this was a post-surgery refraction. Always be prepared for refractive surprise, but it is more important is keep the patient prepared for a refractive surprise, not only you. Okay, so the corneal refractive surgeries group is over. I'll very briefly mention about the keratoconus IOL power calculations. Whenever you have a patient having a keratoconus or a treated keratoconus and a cataract, what are the 3 things that you should be always looking at? The age, the stage, and the stability of the keratoconus. So let's talk about a young patient having about 35 years of age with a stable keratoconus. Of course, you are going to go ahead and do a topography and always use an optical biometry. In fact, I'm not going to go into this discussion of optical versus ultrasound biometry ever in this talk. And the formulas which you would want to prefer are the Haig's L, the Shamas, the Holiday 2, and the Barrett Universal 2. Well, like Dr. Somil mentioned, Barrett Universal 2 is the magic rabbit out of the head. All the results should be in 2 diopters of the Haig's L formula. And this I'm talking about a young patient with a very mild keratoconus and a stable keratoconus. If this is another type variety of patient where the patient is young, the keratoconus is mild, but the stability is not there. What actually are you going to do? Well, you may do a pinhole test, see if the vision improves, then you might think of doing a cross-linking with intrastromal rings and try to shift the cone, or if not improving, well, you can go ahead and do the corneal cross-linking. A middle-aged patient having cataract with stable and mild to moderate keratoconus, again, the fundamentals remain the same. Haig's L, Shamas, Barrett 2, Universal 2, Hills on the ASCRS website, and toric IOLs to be avoided, which is a universal fundamental for all these patients. Supposing you have a middle-aged patient with advanced but stable keratoconus. Why would you say advanced? Well, the Ks are more than 60, the corneal thickness is less than 400. Well, you might, and the posterior float is more than 40 microns. You might consider doing a triple procedure, DALK, phaco, and IOL. But frankly, after this surgery, it hardly matters whether the patient is -2 or -3 or -4 also, because these patients are struggling to get 618, 612 vision. Similarly, an old patient with 60 years and keratoconus with a mild to moderate but very unstable, well, you can think of doing only a cataract surgery and a secondary IOL post the surgery with aversions formulas. Yes. IOL selection, well, very important is the zero sphericity, which is most preferred. So post keratoplasty, corneals carrying a degeneration, all corneas, corneal bypass formulas are to be used. And very important is if the other eye is normal, you can try and go ahead and measure the other eye and try to do the IOL power calculation. Thank you very much for your attention.
Thank you, Dr. Tejas sir, for elaborating such a nice how to manage the abnormal cornea. It's a vast topic to cover in such a short time. Is very difficult. Now I invite Dr. Sahil Vasavada. Everybody knows him. They are the masters in the pediatric cataract management, and they are since so many years. The Raghudeep is the one of the pioneer in research work in the pediatric cataract. So let's hear from him how they are going ahead with the pediatric IOL power calculations. Dr. Sahil Vasavada.
Thank you very much, Dr. Twinkle sir, for this, for inviting me in your wonderful course. And fortunately, I'm going to talk something where we don't need all of these expensive instruments, the biometers, the new formulas. Not too much of knowledge is required. And I think to make a child happy, the easiest way is to just give him vision. They are far less demanding for one diopter and two diopters of error. At the outset, I do acknowledge the support of Dr. Deepa Agrawal, who handles our pediatric department at Raghudeep Eye Hospital. And we do receive research grant support from Alcon Laboratories, but has no financial relevance to this talk. In children, determining an IOL power is one of the major challenges because the eye has only started to grow. So it's not a mature eye in terms of development as well as its growth. And there are three major issues that we look at. First is how do we measure these eyes because these are uncooperative patients. The formulas that you use and what refraction do you target, keeping in mind their growth that is going to come. As far as the biometric measurements go, the basics of keratometry and axial length are something that we all would want to get as accurately as much as possible. And of course, for children less than 3, 4, or 5 years, also sometimes they do not cooperate or allow us to do any measurements on the sitting based equipments like a biometer or a topography or anything. So generally we do the examination under general anesthesia, where a handheld keratometer, now plenty of good ones are available, is used to measure the axial length. Always be careful that not too much pressure is put on the lids with the speculum or the fingers, whatever you're using. And for older children who cooperate, you can use the equipments that you use even for adults. If you want a rough brief idea of the keratometry with age, this is the normative database, and typically the cornea is very steep when the child is born and typically tends to flatten out as the child grows. As far as the method for axial length measurement, immersion is definitely preferable. Immersion can be challenging in very small children because the general normal Prager shell that you have for the immersion is too big for most of the children less than 1 to 2 years of age. Therefore, you may have to get it modified or get it made locally so that it fits properly in a small eye. Contact is something that should be avoided, even like we know in adults, but particularly in children, as this paper and in the very early on period, now almost more than a decade old, had shown that contact in children particularly leads to at least a much shorter axial length compared to even when we measure amongst adults. Optical biometry, as has been highlighted, would be ideal for older children. Coming to the formulas, and in most of the presentations that we heard so far, it's sort of now universal that the Barrett universal formula works well across all ranges, across all different types. In children, there is no consensus, and therefore you see several publications, and each has their own recommendation. So one suggests Holiday 1 is better, some would suggest Hage's SRK2, T, Holiday 2, etc., so on and so forth. And that's because because there are several multiple factors involved in such eyes, whether it was a unilateral cataract, bilateral cataract, associated with microphthalmos, no microphthalmos, so on and so forth. So therefore, there is still no consensus as to which is the most accurate power. And we did our own data analysis, and in our hands, we found the SRKT and the Holiday 2 to be working to be relatively better compared to the other formulas. We are also analyzing our data with the Barrett's Universal, but at present the SRKT and the Holiday 2 are our personal preference. And what interestingly, most of the studies, including our study, found that personalizing lens constants like we do for adults doesn't seem to help much in pediatric eyes. So our choice at the moment is for this. Maybe with the analysis with some of the newer formulas, this may change. Target refraction. Now, this is the most important question. How do you correct the eye completely? Don't correct the eye completely. So the two options are: first is you attempt, and like we do for adults, go for emetropia. Do not undercorrect, overcorrect, do anything. The advantage of that is that immediately the child is likely to see better. So lesser chances of refractive induced amblyopia, but a very, very high chance that the child will end up being extremely high myopic as it grows on. And this is particularly true for very young children. Less than this all mainly applies to younger children. For children more than 7, 8 or 9, these things really may not matter very much. So the other option is to leave behind some hypermetropia, what is called as undercorrection, which has an initial challenge because the child will have to wear relatively higher hypermetropic glasses immediately. But the chances of developing extremes of high myopia are less in the future. So the consensus amongst most pediatric cataract surgeons is to follow the second strategy, that is to leave behind some residual hypermetropia, and how much is debatable. So the age at surgery is an important factor in determining the rate of axial growth of the eye, and there have been studies to show that in the fastest phase of axial length growth is between 0 to 6 months. So if you are operating the congenital cataract, say at 3 months, you have to think of more undercorrection compared to if you are operating at 1 year or 2 years. There's a slower infantile phase from 6 to 18 months, and 18 months onwards is a relatively safer time where you don't expect extreme jumps or extreme prolongation of the axial length, unless, of course, the other eye is also myopic. This is a normative database to show the normal age-related axial length growths among children starting. So the average axial length at birth would be somewhere close to 19 millimeters, which stabilizes or grows significantly in the first year, as you can see, and then the growth is much, much slower, particularly 2 years onwards. So it's higher in children less than 1 year in age. It's higher in pseudophakic eyes than in aphakic eyes. That's also something that we found in our publication where we did a randomized trial comparing bilateral aphakia versus bilateral pseudophakia, 5 years follow-up. And definitely, as understandably, the rate of axial length is far higher in a unilateral pseudophakia, which means a unilateral cataract, which is likely to be anyway the weaker of the two eyes. And visual axis obscuration, or PCO, doesn't seem to affect the rate of axial length growth. So the key point or the key consensus amongst all pediatric cataract surgeons is to undercorrect or leave behind residual hypermetropia. And it depends on the age of the child, the axial length, and the laterality. And like we discussed, if in a unilateral case, the challenges are more for two reasons. One is if you need to look at the refractive or the axial length status of the other eye, whether the other eye is already very myopic for a normal axial length, normal age for the child, you are more likely that this eye is also going to grow more myopic. But the other difficulty with unilateral cataract is that you don't want to create an extremely high level of anisometropia between the two eyes. So unilateral cataracts are a real challenge. And there are several guidelines as to how much to undercorrect or what power to use in the early on period, where only axial length was used as a criteria. The Dahan's guidelines suggested fixed powers for the fixed number of axial length, and they suggested an overall undercorrection of 20% based on the axial length alone. But as time progressed, we realized that axial length, keratometry, age, all of these factors play an important role. And this was another important paper which suggested by Plager and group, which suggested that for younger children, you undercorrect more. And as the child grows older, you undercorrect less. However, this was again for children 3 years and beyond. And the real challenge comes in children less than 1-2 years of age. So Dr. Trivedi, Dr. Rupal Trivedi, Dr. Ed Wilson and their group studied for children even less than 2 years, so 1 year and above. So therefore, for 1 year, they suggest a target refraction of +6 and reducing as the time goes on. From our own data set and our own analysis, we generally don't have a fixed number in mind. We do an undercorrection percentage based on what the calculation formula suggests us. So for children operating under 3 months of age, we undercorrect the power by 35%. 30% for up to 6 months, and keep reducing as the child grows on. And anywhere beyond 6-7 years of age, we do not undercorrect very much significantly. So by undercorrection, what we mean is, say for example, if it's a 9-month child and the metropic IOL power is 32%. So if you undercorrect by 25%, that means you're going to end up actually implanting a 24 diopter IOL. Just a word on toric IOL in children, and we have found that older children who allow us good measurements more than 7-8 years of age, the astigmatism has been shown in several normative databases to be stabilized around 5 to 7 years of age. So you don't see a very major shift in astigmatism or corneal curvature beyond 7 years of age. And this is something we published a couple of years ago, our outcomes of toric IOLs in older children more than 7 years of age. And we found significant reduction in their refractive astigmatism, because remember, astigmatism is one of the leading causes of amblyopia, and you can do a toric IOL even with a PCCC being done inside the eye. The IOLs remain stable. So we have found it to be an important tool for combating amblyopia in older children, and so far it's been the largest series of children with toric IOLs. Multifocal IOLs is something that we discourage, because here our aim is not refraction, our aim is to give good quality vision. And it's very surprising that it's only we grown-ups who are so concerned about glasses. Children, even if you give them +12, +15 glasses, if they can see well, they will adapt it so easily that getting children to wear glasses is generally never an issue. With the advent of extended depth of focus IOL, maybe in older children, this is something that we may be considering in the times to come. But as of now, we have no experience to really talk about it. So to summarize, IOL power calculation in children is very challenging, and the reason for it is that it is extremely multifactorial. And I think there is no one fixed recipe, one fixed formula that works well for all eyes or for all children or in all practices. And we need to look at each eye or each case individually, keeping in mind all of the factors that we discussed about. Thank you so much once again for the patient listening.
Excellent presentation, Dr. Shell. And for the last presentation of this course, I would invite the chief instructor, Dr. Twinkle, who is going to talk to us about the toric calculators.
Thank you, Dr. Tejas. So many new things are coming up in the toric calculators, and everybody is hearing about the posterior coronary astigmatism measurement and correction in the toric calculations. So many nomograms are available. New terminologies are coming up, centered values and IOL tilt factor. So we are going to a little bit understand about the why it's needed and what are the fallacies in the recent toric calculators and which is the coming up, what we really required. So in our regular toric calculator, which up till now we were using, we have a spherical power which was given by optical biometry by using the different variables like XL length, keratometry, anti-chamber depth, white to white, or lens thickness. All these variables has been used. You utilize one formula, whatever the formula you want to use, Barrett or SRKT or whatever, you get the spherical power. And this spherical power used in the toric calculator by using the keratometry, and it gives us a cylindrical power in the axis. But there were some inaccuracies. We are not perfect till date. So where we were lacking was a little bit understanding about the SIA, surgical astigmatism. We were lacking about the effect of the posterior corneal astigmatism understanding, influence of effective lens position on cylindrical power at the corneal plane, position of fovea, optic disc tilt, and the postoperative IOL tilt. We will go detail of each of them. First is SIA. Everybody knows SIA. You for any website, go for the SIA calculations, get your SIA done. But the problem with the SIA was the magnitude. Typically shows the wide variation. Dr. X is operating, he is getting the SIA with the 2.4 millimeter SIA get 3.32, and somebody else is operating and he is getting 0.20. So the magnitude was also typically shows the wide variation. Orientation was also not consistent. Which axis was giving, that was also not consistent. Mean value is not to be applied for individual, but the median value was less sensitive for the outliers. So many outliers will be there, even though you are calculating hundreds of data for your SIA values. So newer thing which coming up is the centered value, because of the better understanding of the measurements and the theoretical model calculations. So because of this, more and more advancement in the power vector method calculations by the supercomputers, and utilizing the different ray tracing analysis cornea by the optical engineering, bioengineering systems, we come to know that rather than putting this angle plot in a single angle plot, you can put in a double angle plot and use the trigonometry application of the vector analysis. And this will give you an average of this vector, and it represented as a mean SIA value that is known as a centered value. So the centered value for the less than 2.2 millimeter incision, it has to be considered as a 0.1, or if it is your incision is nearly 0.28, it should be 1.2, 0.12. It also has been given very well. So even though if you want to calculate your centered value, you can go to astigmatism double angle plot. The same we are using in the SIA calculations. Put your preoperative data, put your postoperative refraction, and what was the predicted refraction, and you will get your centered value. So it is easy to get it. Now another thing which is important to understand is the PCA, posterior corneal astigmatism. Till 2012, we were lacking of this understanding. Standard keratometric and topographic machines were giving us inaccurate results in assessing the net corneal astigmatism power. So Dr. Douglas Cogg has studied 715 eyes of 434 patients, and he found out there is a strong correlation between the front cornea and the back cornea, even it is a with the rule or against the rule astigmatism. And what he found, that most of the posterior cornea are steep vertical. So they are steep vertically, so posterior cornea act as a negative lens. So when it creates a net plus power along the horizontal plane, so it creates against the rule astigmatism. So your patient has a pre-existing with the rule astigmatism, the net effect will be decrease in the with the rule, and suppose patient has against the rule astigmatism, net effect will be increase the against the rule astigmatism. So now over the period of time, in the next year, for this understanding, Dr. Baylor come with the one nomogram that how to apply these variations, and this nomogram has been widely accepted at that time in 2013-2015 time. Nomogram shows better performance than what we are doing by the only corneal topography or anterior keratometry, but they are also based on the limitation by the population averages. They have average power contributions. So what to do? What about the meridian? We were not understanding about the meridian part, and meridian has a significant role for understanding of the total corneal power. So suppose your cornea has a width rule of 3 diopter at 70 degree, and you apply the Baylor nomogram, it gives the 2.3 at the 70 degree only. It is not considering the angular power. But when we measure now, because we have machines, we can measure the total corneal power, and it gives the 60 degree. So that was the lacking in the Baylor nomogram. So we need a total corneal astigmatism measurements. And posterior corneal astigmatism change the net power of the corneal astigmatism on the axis on the net astigmatism plane. So nomogram do not address this issue. Algorithms and direct posterior corneal astigmatism measure can do. So in 2016 we come up that you have to measure the total corneal power rather than going to based on the normograms. So the 1 or 2 years it was considering that the total corneal power is very important, and the IOL Master 700 was introduced and TK value has been introduced. So this was going to be a booming up. So because of these so many machines we can measure the PCA. Now it has been confusion because we have so many nomograms, Wheeler nomogram, Abdullah-Pekko nomogram, Coughlin coefficient. We have so many calculators which are incorporating the total corneal power, or they are assuming considering the nomograms. So whether we have to estimate the PCA power or whether we have to measure the PCA power, that was a very important thing to consider. And this study, landmark study in 2017, come with this widely used formulas like a Barrett or Abdullah-Pekko or Panacea and Panoptics. All these story calculators are widely used, and they had compared it. And the comparison gives that the Barrett-Torrey calculator and Abdullah-Pekko formulas gives the lowest astigmatism prediction error, but they were not superior to the estimation. So even though you are measuring it or whether you are estimating on the nomograms, till that those phase, it was not considering as a superior of any one of that. Another important understanding by this one is the devices are different in the total corneal power measurement. You are measuring total corneal power on the SimFlow. You are measuring total corneal power on the IOL Master 700. So both has a different total corneal power. So even though there is an intervariable problem with the measurement, total corneal power measurement, so which to apply? So that was also confusion. So at present till time it is considered that the estimation and the nomograms both are working very well. So rather than going for what the market says that you buy for the total corneal tomography, there is no need. We have so many good nomograms and they are still giving the equivalent results, not the superior results are there. Of course, they are good to measure the PCA, but it is not necessary for us to utilize the newer machines just to measure the posterior corneal power to buy it. Particularly, things works very well when you are measuring the posterior corneal, when the outliers are there. So you have a very high oblique astigmatism. In such cases, the chances of the prediction error are very high. In such cases, if you are measuring it and you are applying it, it gives a little bit better results. Going for the third thing, influence of effective lens position on cylindrical power at the corneal plane. This is mainly important for the understanding of the which toric calculator you have to use. Because toric calculators are based on the two phenomena. One is the fixed ratio and second is considering the estimation of effective lens position. What do you mean by fixed ratio? Your IOL power astigmatism has to be an astigmatism at the corneal plane. That has to be considered. The fixed ratio toricity, that means 1:1.45. So 1.45 of the corneal plane correction IOL plane will correct the one diopter corneal plane. So those certain toric calculators based on the estimated ELP. Now what is estimated ELP? Because 1:1.45 is okay for the average lens, axial length. But when it is a short axial length or when it is a myopic patient, it should not be like that. When high hyperopia, the ratio is changed from 1.2 to 1. Or when it is a high myopia, it may be shift from 1.75 to 1. So you have to consider these variations in the high myopia and high hyperopic patients. So this is the chart. How do you consider the high myopic patient? How to consider high myopic patients, hyperopic patients? Even the steeper corneas and the flatter corneas also have a different toricity ratio. And this whole thing has been incorporated by the different calculators. So which calculators are incorporating this? These are all the calculators which are considering the effective lens position ratio. But remaining are not. So suppose you are using the Hoya lens and you have a very high myopic patient or you have a very high hyperopic patient. It is not considering effective lens position ratio. So the chances of error is very high. So if you want to use a Hoya lens, then you have to go for the Barrett toric calculator which is available online. So that can be corrected very well. So rather than going for the company's toric power calculator, you should understand which toric calculator has to be considered in which lens. Certain are considering the posterior corneal astigmatism calculations also. So for ideal toric calculator, what we should use? Total corneal estimation is automatically added as a third factor. That is first thing. Second, variable effective lens position, ELP position calculation should be there in your toric calculator. Centered value has to be added, has to be effective in your toric calculator. And calculator, we are giving the spherical IOL power by itself. So rather than relying on your optical biometry and put in the toric calculator, if your toric calculator is getting that one, that the spherical power is also calculated by the toric calculator, that is considered as a best part. So the Barrett is one of the very good tool for that. The next thing which is coming up is the position of fovea and optic disc tilt factor. Still so many studies are going on. This is one of the study that the optic disc orientation to some extent may indicate the steeper meridian of the cornea. This is another study which is also says that the OCD based, that the cornea is considered when the interpreting the optic nerve head and the peripapillary retinal nerve fiber thickness. And lastly, the postoperative tilt factor. We have a newer understanding of the topography of the lens because of this newer tool, that is a OCT based tool which gives the good topography of the lens. Now we have to understand how the lens is positioned inside the eye or how the IOL remains the position inside the eye. So this gives an idea about the equatorial plane position. Equatorial plane position gives us the exact what will be the ELP for this patient. And the 2019 Dr. Douglas Koch and Lee Wang come with this new conclusion of the physiological tilt factor, and most important that it has a significant mirror symmetry between the right eye and the left eye. It also gives a strong correlation between the magnitude and direction between the preoperative crystalline lens and the IOL tilt. So over the period of time we have to understand IOL tilt factor, and that will be incorporated in the toric calculator. One of the toric calculator, Panacea toric calculator, is now giving the tilt factor also. I have told in my first lecture that the Panacea calculator is giving the tilt factor. So newer generation toric calculator will come with the tilt factor calculations. So in summary, instead of SIA value, use the centered value. At present scenario, total corneal power estimation measurement, both are the equivocal. No need to buy the hi-fi equipments for the posterior corneal power. Use the toric calculator which are incorporating all these centered values, PC estimations, variable toricity ratio, and inbuilt spherical IOL power calculations. And upcoming toric calculators are coming with the tilt factor elements. Thanks for your attention.
Excellent. And the last one is the effective head tilt position. It depends upon your head tilt also.
Depending upon the talk also. So I thank you all the attendees and all the speakers for to be participating in my course. Thank you. Thank you all.